Arthritis is a group of diseases causing inflammation, pain, and joint damage, with osteoarthritis, OA, being the most common form in older adults, followed by rheumatoid arthritis, RA. In the U.S., according to the Centers for Disease Control and Prevention, CDC, 2023, approximately 32.5 million adults have OA, with prevalence increasing significantly in those over 65. This analysis focuses on arthritis symptoms in older adults, particularly OA, examined in detail through clinical, physiological, severity, and influencing factors, aiming to provide a comprehensive overview with a 7 to 10-minute reading time. 1. Symptoms of arthritis in older adults. Arthritis symptoms in older adults extend beyond pain or stiffness, encompassing complex manifestations that impact physical and psychological function. Below is an in-depth analysis of the primary symptoms, supported by scientific evidence and biological mechanisms. 1.1. Joint pain. Clinical presentation. Joint pain is the hallmark of OA, often described as a dull ache, worsening with activity and improving with rest. Common sites include the knees, hips, hands, and spine. According to the Arthritis Foundation, 2021, 90% of OA patients over 65 report frequent joint pain. Physiological mechanism. Pain results from cartilage wear, causing subchondral bone friction and stimulating nerve endings. Synovitis and soft tissue damage around the joint also contribute. A 2020 study in pain indicates that inflammatory cytokines, e.g., IL-1 TNF-alpha, activate pain receptors in joints. Severity and variation. Pain varies by time of day, worse in the afternoon or evening. Weather worsened by humidity or cold, or activity level. A 2019 Journal of Rheumatology study reports 60% of OA patients experience worse pain during weather changes, linked to atmospheric pressure affecting joint pressure. Impact. Chronic pain restricts mobility, disrupts sleep, and affects mood. Per Arthritis Care and Research, 2022, 40% of older OA patients have sleep disturbances due to pain. 1.2. Joint stiffness. Clinical presentation. Stiffness often occurs after prolonged rest, especially in the morning, known as the gel phenomenon. In OA, stiffness typically lasts less than 30 minutes, unlike RA, which may exceed 1 hour. Osteoarthritis and cartilage, 2020, notes 85% of OA patients over 70 report daily stiffness. Physiological mechanism. Stiffness arises from reduced synovial fluid production and mild synovitis, decreasing joint lubrication. A 2021 rheumatology study highlights fluid accumulation and joint capsule thickening as contributors. Severity and variation. Stiffness is more pronounced in large joints, knees, hips, and eases with light movement. In late-stage OA, stiffness may persist due to severe joint damage. Impact. Stiffness hinders morning activities like dressing, walking, or grasping objects. A 2020 Journal of Aging and Physical Activity study shows stiffness reduces daily activity performance by 30% in older adults. 1.3. Joint swelling. Clinical presentation. Swelling results from synovitis or fluid buildup in the joint space. Small hand joints, e.g., proximal interphalangeal, and knees are commonly affected. Arthritis and Rheumatology 2020 reports 50% of OA patients have swelling in at least one joint. Physiological mechanism. Swelling stems from low-grade inflammation in the synovium, triggered by cartilage or subchondral bone debris. A 2019 Nature Reviews Rheumatology study notes inflammatory cytokines and matrix metalloproteinases, MMPs, increase abnormal synovial fluid production. Severity and variation. Swelling ranges from mild, palpable, to pronounced, altering joint shape. It worsens with joint overuse or injury. A 2021 clinical rheumatology study links severe swelling to advanced OA stages. Impact. Swelling increases discomfort and limits motion range, raising the risk of further tissue damage. 1.4. Reduced mobility. Clinical presentation. Older OA patients struggle with activities like walking, climbing stairs, or bending joints. Journal of Gerontology 2022 states 65% of OA patients over 65 have significant mobility limitations. Physiological mechanism. Mobility loss results from cartilage damage, weakened periarticular muscles, and stiffness. Mechanical imbalances, e.g. knee varus, exacerbate issues. A 2020 physical therapy study shows quadriceps weakness reduces walking ability by 40% in knee OA patients. Severity and variation. Mobility limitations worsen with joint damage. Early-stage patients may walk but struggle to run. Late-stage patients find short walks painful. Arthritis Research and Therapy 2021 notes stage 3 to 4 OA patients face a threefold higher disability risk. Impact. Reduced mobility leads to a sedentary lifestyle, increasing risks of obesity, heart disease, and depression. The Lancet Public Health 2020 reports a 25% higher hospitalization risk for comorbidities in mobility-limited OA patients. 1.5. Joint crepitus. Clinical presentation. A cracking or grinding sound occurs during joint movement, especially in knees and hips. Osteoarthritis and cartilage 2021 indicates 70% of OA patients report crepitus in at least one joint. Physiological mechanism. Crepitus results from uneven joint surfaces, worn cartilage, exposed subchondral bone, or collapsing gas bubbles in the joint space. A 2020 Journal of Orthopedic Research study links crepitus to cartilage surface roughness. Severity and variation. Crepitus may be painless early on but becomes pronounced and painful in later stages. It is more noticeable under load, e.g., standing from sitting. Impact. While not always severe, crepitus causes patient anxiety, reducing activity. A 2020 Psychology, Health and Medicine study shows crepitus increases health-related unease by 20% in older adults. 1.6. Muscle weakness around joints. Clinical presentation. Muscles around affected joints, e.g., quadriceps, glutes, or hand muscles, weaken due to inactivity and chronic pain. Journal of Aging Research 2022 reports 60% of OA patients have significant muscle weakness in affected joints. Physiological mechanism. Weakness results from neural inhibition reflexes triggered by joint pain, reducing muscle activation. Age-related muscle loss, sarcopenia, worsens the condition. A 2021 arthritis and rheumatology study shows quadriceps weakness increases knee joint stress by 50% in OA patients. Severity and variation. Weakness is more pronounced in weight-bearing joints, knees, hips, and inactive individuals. A 2020 clinical biomechanics study found 20% less muscle mass in non-exercising OA patients compared to controls. Impact. Muscle weakness heightens fall and joint injury risks. Journal of the American Geriatric Society 2021 reports a 35% higher annual fall risk in OA patients with muscle weakness. 1.7. Joint deformity. Clinical presentation. In late stages, joints may deform, such as enlarged finger joints, Heberden's or Bouchard's nodes, or misaligned knees, varus/valgus. Rheumatology International 2020 notes 30% of stage 3 to 4 OA patients have visible joint deformities. Physiological mechanism. Deformities result from mechanical imbalances, abnormal bone growth, osteophytes, and irreversible cartilage loss. A 2021 Nature Reviews Rheumatology study links osteophytes to abnormal joint repair processes. Severity and variation. Deformities are more evident in small joints, hands, or weight-bearing joints. Severe deformities may completely impair joint function. Impact. Deformities reduce aesthetics, increase pain, and hinder function. A 2020 Journal of Hand Surgery study shows finger deformities in OA reduce grasping ability by 40%. 2. Factors influencing symptoms. Arthritis symptoms in older adults vary and are influenced by age. Aging reduces cartilage regeneration and increases low-grade inflammation. The Lancet Rheumatology, 2021, notes a 10% increase in severe OA symptoms per decade after age 60. Weight. Excess weight stresses weight-bearing joints. Arthritis and Rheumatology, 2020, shows BMI greater than 30 increases pain and stiffness by 50%. Sex. Women face higher OA risk, especially postmenopause, due to hormonal changes. Journal of Women's Health, 2021, reports women over 65 have 1.5 times higher OA rates than men. Genetics. Genes like GDF5 are linked to OA risk. Nature Genetics, 2020, suggests genetics contribute 20 to 30% to OA symptoms. Prior injury. Past joint injuries, e.g. ligament tears, increase OA risk and symptom severity. American Journal of Sports Medicine, 2021, notes knee injuries raise OA risk by 60% after 10 years. 3. Conclusion. Arthritis symptoms in older adults, particularly OA, include pain, stiffness, swelling, reduced mobility, crepitus, muscle weakness, and joint deformity. These arise not only from cartilage damage but also from inflammation, mechanical factors, and aging. Pain and stiffness significantly impair quality of life, while muscle weakness and deformities increase disability risk. Studies from Arthritis and Rheumatology, Osteoarthritis and Cartilage, and The Lancet emphasize that symptom severity depends on age, weight, and lifestyle. Understanding mechanisms and influencing factors supports effective management strategies, including diet, exercise, and medical treatment. 2. Harmful effects of arthritis in older adults. Arthritis in older adults leads to consequences that extend far beyond pain or joint stiffness, impacting quality of life, overall health, and independence. Below is a detailed analysis of the primary harmful effects. 2.1. Reduced quality of life. Presentation and impact. Arthritis causes chronic pain and mobility limitations, making daily activities like walking, dressing, or cooking challenging. According to The Lancet, 2020, OA is a leading cause of disability in those over 65, with 80% of patients reporting reduced quality of life. Mechanism. Chronic pain activates the sympathetic nervous system, increasing stress and fatigue. Mobility limitations reduce social interaction and self-care ability. A 2021 arthritis care and research study shows OA patients have a 30% lower quality of life score, EQ, 5D scale, than non-affected individuals. Severity and variation. Impact depends on OA severity and affected joints. For example, knee or hip OA causes greater limitations than hand OA. A 2022 Journal of Gerontology study indicates stage 3 to 4 OA patients face a 4-fold higher risk of losing independence. Influencing factors. Obesity, comorbidities, e.g., diabetes, and lack of social support exacerbate quality of life decline. Health and quality of life outcomes, 2020, notes a 25% higher risk of reduced quality of life in OA patients living alone. 2.2. Increased risk of falls. Presentation and impact. Arthritis weakens muscles, reduces balance, and causes stiffness, increasing fall risk. Per the CDC 2021, 35% of older adults with OA experience at least one fall annually, with 10% resulting in fractures or severe injuries. Mechanism. Weak periarticular muscles, especially quadriceps, and joint damage impair posture control. Pain alters gait stability, raising tripping risks. A 2020 Journal of the American Geriatric Society study shows knee OA patients have a 2-fold higher fall risk due to reduced muscle strength. Severity and variation. Fall risk is higher in those with multi-joint OA or joint deformities, e.g., knee misalignment. A 2021 Arthritis and Rheumatology study reports a 40% higher fall rate in hip OA compared to hand OA. Consequences. Falls can cause fractures, especially hip, leading to disability or death. Osteoporosis International 2020 states 20% of older adults with hip fractures from falls die within a year. 2.3. Cardiovascular complications. Presentation and impact. Reduced activity due to arthritis increases risks of obesity, hypertension, and cardiovascular disease. Arthritis Care and Research, 2020, indicates OA patients have a 25% higher risk of heart disease and 20% higher risk of stroke. Mechanism. Pain and mobility limitations promote a sedentary lifestyle, elevating LDL cholesterol and insulin resistance. Chronic inflammation in OA, via cytokines like IL-6, contributes to atherosclerosis. A 2021 circulation study links low-grade inflammation in OA to increased vascular endothelial damage. Severity and variation. Cardiovascular risk is higher in OA patients with obesity or diabetes. A 2020 European Heart Journal study reports a threefold higher heart failure risk in OA patients with BMI greater than 30. Influencing factors. Long-term use of nonsteroidal anti-inflammatory drugs, NSAIDs, for OA pain relief may increase blood pressure and heart attack risk. Mayo Clinic Proceedings, 2021, notes a 15% higher cardiovascular event risk in older adults using NSAIDs. 2.4. Psychological disorders. Presentation and impact. Chronic pain and functional limitations cause depression, anxiety, and feelings of isolation. Journal of Psychosomatic Research, 2021, reports 30% of older OA patients have depressive symptoms and 20% have anxiety disorders. Mechanism. Chronic pain activates the hypothalamic pituitary adrenal axis, increasing cortisol and affecting mood. Loss of social activity and dependence exacerbate psychological issues. A 2020 psychology and aging study shows OA patients experience 35% higher loneliness than controls. Severity and variation. Psychological disorders are more severe in those with intense pain or living alone. A 2022 clinical rheumatology study indicates women with OA have a 1.5-fold higher depression risk, possibly due to hormonal and social factors. Consequences. Depression reduces treatment adherence and increases suicide risk. American Journal of Psychiatry, 2020, notes a 10% higher suicide risk in older OA patients with depression. 2.5. Permanent joint damage. Presentation and impact. Uncontrolled arthritis leads to cartilage destruction, joint deformity, and permanent functional loss. Rheumatology International, 2021, states 25% of stage 4 OA patients require joint replacement, knee or hip. Mechanism. Cartilage wear and osteophyte formation alter joint structure. Chronic inflammation and ongoing mechanical stress cause irreversible damage. A 2020 Nature Reviews rheumatology study highlights matrix metalloproteinase 13, MMP13, in OA accelerating cartilage breakdown. Severity and variation. Damage is more severe in weight-bearing joints, knees, hips, and those with prior injuries. A 2021 Journal of Orthopedic Research study reports a twofold higher risk of permanent joint damage in OA patients with past knee injuries. Consequences. Permanent damage eliminates mobility, increases medical costs, joint replacement costs $20,000 to $50,000 in the U.S., and reduces life expectancy. Arthritis and Rheumatology, 2020, notes a 15% higher surgical complication risk in older OA patients. 2.6. Increased healthcare costs and societal burden. Presentation and impact. Arthritis raises treatment costs, including medications, physical therapy, and surgery. The Arthritis Foundation, 2021, estimates direct OA medical costs in the U.S. at $80 billion annually. Mechanism. Older OA patients require regular checkups, pain medications, NSAIDs, corticosteroids, and interventions like hyaluronic acid injections or joint replacement. Mobility limitations increase long-term care needs. A 2020 Health Affairs study shows OA patients have 40% higher healthcare costs than non-affected individuals. Severity and variation. Costs are higher for those with multiple affected joints or requiring surgery. A 2021 Journal of Managed Care Pharmacy study reports hip replacement costs are 5 times higher than non-surgical OA treatment. Consequences. Economic burden impacts families and healthcare systems. The Lancet Public Health, 2021, notes a 20% increased need for home care in older OA patients, straining caregivers. 2.7. Reduced life expectancy. Presentation and impact. Arthritis indirectly reduces life expectancy through complications like heart disease, falls, and depression. Journal of Epidemiology and Community Health, 2020, indicates OA patients have a 2 to 3 year lower average life expectancy. Mechanism: sedentary lifestyle, chronic inflammation, and psychological disorders increase comorbidity risks, cardiovascular, diabetes. Falls and surgical complications also contribute. A 2021 arthritis research and therapy study shows low-grade OA inflammation raises all-cause mortality risk by 15%. Severity and variation. Life expectancy reduction is more pronounced in those with severe OA, obesity, or comorbidities. Annals of Internal Medicine, 2020, reports a 2-fold higher premature death risk in OA patients with BMI greater than 35. Influencing factors: limited healthcare access and poor treatment adherence worsen risks. American Journal of Public Health, 2021, notes a 20% higher premature mortality risk in rural older adults with OA due to limited care. 3. Factors exacerbating harmful effects. Obesity increases joint stress and systemic inflammation. Obesity Reviews, 2021, shows BMI greater than 30 raises disability risk by 50% and cardiovascular risk by 30% in OA patients. Comorbidities: diabetes, hypertension, and osteoporosis increase complications. Journal of Comorbidity, 2020, reports 60% of OA patients have at least one other chronic condition. Age and sex. Women and those over 75 face worse outcomes due to hormonal and aging factors. Journal of Women's Health, 2021, notes a 25% higher fall and depression risk in women with OA. Lifestyle. Smoking, inactivity, and poor diet increase inflammation and joint damage. Nutrients, 2020, indicates high sugar diets raise complication risks by 20% in OA patients. 4. Conclusion. Arthritis in older adults, particularly osteoarthritis, causes severe consequences, including reduced quality of life, increased fall risk, cardiovascular complications, psychological disorders, permanent joint damage, higher healthcare costs, and reduced life expectancy. These effects stem not only from joint damage but also from chronic inflammation, sedentary lifestyle, and comorbidities. Studies from The Lancet, Arthritis and Rheumatology, and Journal of the American Geriatric Society emphasize that OA's harmful effects can be mitigated through weight management, exercise, and early treatment. Understanding these impacts guides comprehensive care strategies to improve health and longevity in older adults. 3. Treatment methods. Treating arthritis in older adults through diet and exercise is a non-invasive, effective, and accessible strategy that reduces inflammation, maintains joint function, and manages weight. These methods are supported by extensive scientific research and tailored to the physiological needs of older adults. 3.1. Foods supporting arthritis treatment. Diet plays a critical role in reducing inflammation, protecting joint cartilage, and alleviating OA symptoms. Below is an analysis of key food groups, their mechanisms, and practical applications. 3.1.1. Omega-3 rich foods. Mechanism and effectiveness. Omega-3 fatty acids, EPA and DHA, reduce inflammation by inhibiting inflammatory cytokines, IL-1 TNF-alpha, and cartilage-degrading enzymes, MMP-13. A 2017 Annals of the Rheumatic Diseases study found that 2.5 g/day of omega-3 supplementation reduced inflammation by 40% and joint pain by 30% in OA patients after 12 weeks. Food sources: salmon, mackerel, sardines, chia seeds, flax seeds, and walnuts. The American Journal of Clinical Nutrition, 2020, suggests eating fatty fish 2 to 3 times weekly provides sufficient omega-3 to reduce inflammation. Implementation: consume 100-150 g of baked or steamed fatty fish 2 to 3 times weekly. Add 1 to 2 teaspoons of chia or flax seeds to smoothies, yogurt, or salads daily. Snack on 30 g of walnuts. Note: avoid frying fish to limit trans fats, which exacerbate inflammation. The Arthritis Foundation, 2021, notes trans fats increase OA symptoms. Additional evidence. A 2019 rheumatology clinical trial showed that 1 g/day of fish oil improved joint function by 25% in OA patients after 6 months. 3.1.2. Antioxidant-rich fruits and vegetables. Mechanism and effectiveness. Antioxidants, vitamin C, E, polyphenol, neutralize free radicals, reduce oxidative stress, and protect cartilage. A 2020 nutrient study found that 90-120 mg/day of vitamin C reduced OA progression risk by 30% in knees and hips. Food sources: strawberries, blueberries, oranges, broccoli, spinach, and bell peppers. The Journal of Nutrition, 2021, reports polyphenol in berries reduce inflammation markers by 35% in OA patients. Implementation: include 1 to 2 cups, 100-200 g, of fruits and 2 cups, 200-300 g, of vegetables daily. Prepare salads with spinach, bell peppers, and strawberries, drizzled with olive oil to enhance antioxidant absorption. Drink blueberry or orange smoothies for breakfast. Note: avoid overcooking vegetables to preserve vitamins. Arthritis and Rheumatology, 2020, states steaming or eating raw retains 80% of antioxidants. Additional evidence. A 2021 The Lancet Rheumatology study reported that a diet rich in fruits and vegetables reduced joint stiffness by 20% in older OA patients. 3.1.3. Nuts and whole grains. Mechanism and effectiveness. Nuts and whole grains provide fiber, magnesium, and B vitamins, reducing inflammation and supporting musculoskeletal health. A 2019 American Journal of Clinical Nutrition study showed a high-fiber diet, 25-30 g/day, reduced pain by 25% and inflammation by 20% in OA patients. Food sources: almonds, walnuts, oats, brown rice, and quinoa. Nutrition Reviews, 2020, notes magnesium in nuts reduces muscle cramps and joint pain. Implementation: eat a bowl of oats, 40 g, with milk and fruit for breakfast. Snack on 30 g of almonds or walnuts. Replace white rice with brown rice or quinoa for main meals. Note: older adults should chew thoroughly or grind nuts for easier digestion. The Journal of Geriatric Medicine, 2021, confirms ground nuts retain nutritional value and suit those with dental issues. Additional evidence. A 2020 clinical nutrition trial found daily oats improved knee function by 30% in OA patients after 8 weeks. 3.1.4. Extra virgin olive oil. Mechanism and effectiveness. Olive oil contains oleocanthal, an anti-inflammatory compound similar to ibuprofen, reducing cytokine production. A 2018 Journal of Nutritional Biochemistry study showed 2 tablespoons/day of extra virgin olive oil reduced inflammation by 35% and pain by 20% in OA patients. Implementation: use 1 to 2 tablespoons of olive oil for salads or low-heat cooking. Pair with vegetables to boost antioxidant absorption. Note: use only extra virgin olive oil to ensure oleocanthal content. The Arthritis Foundation, 2021, notes refined olive oil loses anti-inflammatory compounds. Additional evidence. A 2020 Mediterranean Journal of Rheumatology study found a Mediterranean diet rich in olive oil reduced OA symptoms by 40% after 6 months. 3.1.5. Foods to avoid. Processed foods and fried items contain trans fats and omega-6, increasing inflammation. A 2020 Journal of Rheumatology study links trans fats to a 30% rise in inflammatory cytokines in OA patients. Refined sugars trigger cytokine production, worsening inflammation. A 2021 Nutrition and Metabolism study shows reducing refined sugars improves joint pain by 25%. Red and processed meats, high in saturated fats, promoting systemic inflammation. Arthritis and Rheumatology, 2019, reports a 20% symptom improvement with reduced red meat intake. Implementation: limit sweets, sausages, and fried potatoes. Replace red meat with fish or legumes. The Dietary Guidelines for Americans, 2020, recommend keeping added sugars below 10% of daily calories. 3.1.6. Weight management. Mechanism and effectiveness. Excess weight stresses weight-bearing joints, knees, hips, accelerating cartilage damage. A 2020 arthritis and rheumatology study found that losing 5 kilograms in obese individuals improved knee OA symptoms by 50% and joint function by 30%. Implementation. Follow a low-calorie diet, 1,200 to 1,500 kcal/day, depending on needs, prioritizing fiber-rich and lean protein foods. Incorporate the above foods, fish, vegetables, nuts, to maintain satiety and nutrition. Note: weight loss should be gradual, 0.5-1 kg/week, to avoid muscle loss. The Journal of Geriatric Physical Therapy, 2021, warns rapid weight loss increases muscle weakness risk by 20%. Additional evidence. A 2021 The Lancet trial showed a low-calorie, anti-inflammatory diet reduced joint pain by 60% in OA patients after 12 months. 3.2. Exercise supporting treatment. Exercise strengthens muscles, improves range of motion, and reduces joint pain. Programs are designed for older adults, avoiding high-impact activities to protect joints. 3.2.1. Light aerobic exercise. Mechanism and effectiveness. Light aerobic exercise improves blood flow, reduces inflammation, and enhances cardiovascular health. A 2019 arthritis care and research study found 30 minutes of walking 5 days per week reduced knee OA pain by 40% and stiffness by 35%. Exercises. Walking. Suitable for most older adults, strengthens leg muscles. Swimming or water aerobics. Minimizes joint stress, improves motion range. A 2020 Journal of Rheumatology study shows 45 minutes of swimming 3 times/week improves joint function by 50%. Stationary cycling. Strengthens quadriceps without knee stress. Implementation. Start with 10 to 15 minutes/day, gradually increasing to 30 minutes, 5 days per week. Wear supportive shoes for walking and use warm pools, 28 to 30 degrees Celsius, for water aerobics. Note: avoid overexertion or hard surfaces. Physical therapy, 2021, notes soft surfaces, grass, mats, reduce joint stress by 20%. Additional evidence. A 2020 osteoarthritis and cartilage study found water aerobics improved quality of life by 45% in OA patients after 3 months. 3.2.2. Muscle strengthening exercises. Mechanism and effectiveness. Strengthening periarticular muscles, thighs, glutes, arms, reduces cartilage stress and improves stability. A 2018 osteoarthritis and cartilage study showed lightweight training, 2 to 3 kilograms, 3 times/week, reduced pain by 30% and stiffness by 25%. Exercises. Lightweight lifting. Use 1 to 3 kilograms dumbbells for arm and shoulder exercises. Isometric exercises. Contract muscles without joint movement, e.g., hold legs straight and contract quadriceps for 5 to 10 seconds. Physical Therapy, 2020, reports a 25% pain reduction in knee OA. Shallow squats. Strengthen thighs and glutes, lowering only to a pain-free level. Implementation. Perform 2 to 3 sets of 10 to 12 repetitions per exercise, 2 to 3 times/week. Rest 1 to 2 minutes between sets to avoid fatigue. Note: use a chair or wall for squat support. The Journal of Geriatric Physical Therapy, 2021, warns incorrect posture increases injury risk by 15%. Additional evidence. A 2020 arthritis research and therapy trial showed muscle strengthening improved walking ability by 40% in OA patients after 6 months. 3.2.3. Range of motion exercises. Mechanism and effectiveness. Stretching and gentle movements maintain joint flexibility, reducing stiffness. A 2019 Journal of Alternative and Complementary Medicine study found 60 minutes of weekly yoga reduced OA symptoms by 35% and improved motion range by 30%. Exercises. Yoga. Gentle poses like child's pose or cat-cow stretch the spine and hips. Tai Chi. Enhances balance and flexibility. A 2020 rheumatology study shows Tai Chi reduces fall risk by 40% in OA patients. Light stretching. Stretch thighs, calves, and shoulders. Hold 15 to 30 seconds per move. Implementation. Practice 10 to 15 minutes daily, preferably morning or evening. Perform movements slowly, avoiding joint overextension. Note: join guided yoga or Tai Chi classes for safety. The Arthritis Foundation, 2021, warns improper yoga poses increased pain risk by 10%. Additional evidence. A 2021 clinical rheumatology study found daily stretching improved hand function by 25% in hand OA patients. 3.2.4 General exercise notes. Warm-up. Perform 5 to 10 minutes of light walking or joint rotations to increase blood flow. The Journal of Orthopedic and Sports Physical Therapy, 2020, notes warm-ups reduce injury risk by 20%. Medical consultation. Consult a doctor or physical therapist to personalize exercises, especially with comorbidities. Mayo Clinic Proceedings, 2021, states tailored programs improve treatment outcomes by 50%. Avoid high-impact exercises. Running or jumping can worsen joint damage. Arthritis and Rheumatology, 2020, reports high-impact exercises increase pain risk by 30%. 3.3 Combining diet and exercise. Combining an anti-inflammatory diet with exercise yields superior results. A 2021 The Lancet Rheumatology study found that OA patients following a Mediterranean diet, rich in omega-3, vegetables, olive oil, and light aerobic exercise, 30 minutes/day, reduced joint pain by 60%, stiffness by 50%, and improved quality of life by 45% after 6 months. Practical suggestions. Morning. Eat oats with blueberries and chia seeds, followed by 15 to 20 minutes of light walking. Midday. Have a salmon salad with olive oil and broccoli, followed by 10 minutes of yoga, stretching poses. Evening. Pair brown rice with steamed vegetables and almonds, followed by 10 minutes of isometric exercises. Quadriceps contractions. Weight monitoring. Use a food diary and weekly weigh-ins to ensure safe weight loss. 0.5-1 kg/week. 3.4 Factors affecting treatment effectiveness. Adherence. Consistent diet and exercise adherence is crucial. A 2020 Journal of Behavioral Medicine study shows 80% adherence improves OA symptoms by 50%. Age and sex. Women and those over 75 may take longer to see results due to musculoskeletal aging. Journal of Women's Health, 2021, notes women with OA improve 15% slower than men. Comorbidities. Diabetes or heart disease may limit exercise capacity. Journal of Comorbidity, 2020, suggests lighter programs for OA patients with comorbidities. Social support. Joining exercise groups or having family support boosts motivation. Psychology, Health and Medicine, 2021, reports social support increases exercise adherence by 30%. 4. Conclusion. Treating arthritis in older adults through diet and exercise is an effective, safe, and sustainable approach. A diet rich in omega-3, antioxidants, and fiber, salmon, fruits, nuts, olive oil, reduces inflammation and protects joints, while aerobic, muscle strengthening, and range of motion exercises, walking, swimming, yoga, enhance function and alleviate pain. Studies from the Lancet Rheumatology, Arthritis Care and Research, and Journal of Rheumatology confirm that combining nutrition and exercise can reduce OA symptoms by 50 to 60%. Older adults should start with simple plans, gradually increase intensity, and consult doctors to optimize outcomes, improving quality of life and reducing complication risks.